I became a nurse originally to become a midwife, and while I was in nursing school, one of my rotations was a geriatric rotation, and I loved it.
I think I always wanted to be a nurse. I can remember when I was 4 years old, my favorite dress-up outfit was a nurse's uniform, so maybe it was something I was born to do.
I just got married very young and had children, and then when the time was right, I went to, and I wanted to work in a hospital, of course, but I've never worked in a hospital. I fell in love with the geriatrics, and that's where I've been ever since.
You just don't provide the physical needs, you also provide emotional needs as well.
I think nursing is a fabulous profession. It's certainly been wonderful to me being able to help improve the quality of care that nursing home residents receive.
Caring for vulnerable populations with long-term care needs is challenging yet rewarding. Every day you use your knowledge and skills to improve the quality of life for your residents. No one knows your residents better, and no one can make a bigger difference. In this video, we're going to discuss resident interviews included in MDS 3.0 to enhance resident assessment and care. These resident interviews are one of the most important changes to MDS version 3.0 because they give the residents a clear voice in identifying their needs and improve the consistency of MDS coding. This video will explain why resident interviews are used and demonstrate approaches to the interviews that can improve communication. We will also show you each interview. We hope this information will help you conduct the interviews effectively. I'd like to introduce Dr. Deborah Saliba, a geriatrician who is the principal investigator for the MDS 3.0 national testing. In addition to providing care for those with long-term care needs, she's the director of the Boren Center, a research center that is nationally recognized for its work to improve long-term care quality.
The primary goal in revising MDS was to improve its clinical relevance and accuracy. One of the most significant clinical improvements in MDS 3.0 is the direct inclusion of resident voice in the assessment. The MDS 3.0 sections that are based on direct resident interviews are cognition, mood, pain, preferences for customary routine, preferences for activities, and return to the community. Many folks helped ensure that MDS 3.0 worked in real nursing homes with real residents. These folks included social workers, activity directors, therapists, and dietitians. Today, you will hear from 3 of the 120 nurses who helped test MDS 3.0.
The residents they loved being interviewed. They really enjoyed having someone come in and sit down and pay attention to them and care about them and want to know what they wanted.
For these MDS interviews, specific questions are asked and response choices are reviewed with the resident. The structure is important because we know that general unfocused questions do not elicit meaningful or valid responses. No matter how bad our day or how we are feeling, most of us will answer fine if asked in passing, "How are you today?" The inclusion of specific questions and responses ensures that MDS items are based on well-tested approaches, are more likely to be reliable across facilities, and provide a common language for communication across settings.
We have one floor at our facility that has dementia on it only, and that was a tough floor for us to go in and interview because we thought they weren't going to be able to follow through with the interview and we were going to have to ask the nurse. And we went into one room and this lady, we were asking her questions and she said yes, yes, yes. And then we got to a question and she says, "Oh no, never, I would never do that." So that told us that she was understanding what we were saying to her, where I would have attempted the interview, but I don't believe that she would have been able to do the interview, but she did, and she followed through, and she did the entire interview with us, and she did a good job.
The idea of using direct interviews is not unique to MDS. Many nursing homes already use them in care. In other healthcare settings, direct interviews have become the most accepted and valid approach for assessing mood, pain, preferences, and cognition. How do we know it works in nursing homes? Based on clinical experience and testing, we know residents can answer questions about how they feel and what they want. The direct interviews in MDS 3.0 have been tested in nursing homes where they have been found to be very effective. Before including a specific interview in MDS, we took several steps. We reviewed scientific research and obtained input from providers and consumers. Then we tested possible item and response wording with nursing home residents. Finally, the interview items were tested as part of the MDS assessment by nursing home providers with over 4,500 residents in 91 community and VA nursing homes across the nation.
I really enjoyed doing the MDS 3.0 interviews. It gave us an opportunity to learn things about the resident that we never learned on the MDS 2.0. We were able to ask them specifically what was important to them, and it changed the whole assessment from being more about what the nurse thought about the resident to what the resident felt about themselves and what their interests were.
Having long-standing relationships with your residents is indeed very important for their care. However, even in long-stay residents in excellent facilities, we can miss important needs if we rely solely on our impressions. Almost 9 out of 10 nursing home staff who tested the MDS 3.0 reported that it provided a more accurate report of their residents' characteristics. Multiple studies have shown that when we do not use direct structured interviews, we too often underestimate the nursing home residents' mood and pain, and we are inaccurate in guessing their preferences and cognitive abilities. In short, if we don't ask in a specific structured way, the resident suffers in silence.
We've had people that have been depressed that we didn't realize they were depressed until we did the 3.0. And we would get them on antidepressant or something, and it really helped their quality of care.
At this point, many may say, okay, it's a good idea, but is it really feasible in nursing homes, especially with the number of residents who have cognitive impairment? The answer is absolutely yes. Residents can answer these questions. The national test included short and long-stay residents scheduled for MDS assessments. As a result, the interviews were tested in residents with a variety of characteristics, including cognitive impairment and dementing illness. This national test confirmed that almost all residents with moderate impairment, and even some residents with severe impairment, can provide reliable and accurate answers to the questions. In fact, in the national test, over 84% of nursing home residents completed the interviews.
It was amazing, the residents we were able to interview just by using the cards, by using the amplifier, just by not going in with the attitude that they couldn't, but going in with the attitude that perhaps they could.
Interviewing takes time, but it takes less time than reviewing pages of medical records and querying staff observers across all shifts. We track the time needed to conduct all of the interviews with actual nursing home residents. The average combined time to complete cognition, mood, daily preferences, activity preferences, and pain was 17 minutes. Simply record the resident's answers directly on the MDS form. If the resident answers the questions, you have completed that section of the assessment.
MDS 3.0, the instructions are right there, and it's pretty easy to follow.
When I first worked on them, I wasn't sure if they were going to work or not, and yet after we started doing them, they were amazingly simple, and the results we got were incredible.
It came out to be a clearer picture of the resident.
Rena Shepard is the past chair of the board of the American Association of Nurse Assessment Coordinators, a national organization focused on improving and supporting assessment in long-term care.
This is a process that can really help improve the quality of care for nursing home residents. As a clinician, receiving information directly from the resident who's telling you about his pain or his feelings or his needs or preferences, it becomes really easy to work with him and the team to develop a care plan based on that very resident-specific information. The MDS interviews will provide great information and in a common language that can really help the team to meet the resident's needs.
At the same time, the MDS 3.0 interviews are just the beginning of the process. It's not possible to do an in-depth assessment for every possible issue. So the residents' responses will help the team to understand what's important to the resident, which in turn helps to identify the priorities for in-depth follow-up and care planning. In fact, certain responses entered on the MDS 3.0 will trigger a reminder that further assessment of the particular care area is necessary. This is the care area assessment component of the MDS 3.0 process.
At the beginning of training, many of the staff who participated in the MDS national test were hesitant about the interviews. However, after learning some simple interview techniques and actually using the interviews with residents, most were pleasantly surprised by the gains in information and time. Particular interview approaches can increase response rates in our vulnerable residents. The next section of the video will highlight techniques that will help you in various interview situations. Let's watch the beginning of one interview.
Great. Can I help you turn the chair around? Great. Right. Here. Mrs. White? Mrs. White?
Yes?
Thank you for agreeing to come to your room to talk with me. As I said in the rec room a few minutes ago, my name is April, and I'm one of the nursing staff here at Eastern Home.
Who?
My name is April, and I'm a nurse here at Eastern Home.
Okay, April.
Is it all right if I take a few minutes to talk with you?
Yes,
Great.
okay.
Should I sit here? Can you see me and hear me?
Oh, could you come a little closer?
Sure, of course.
There.
Now, I need to understand that you can hear me. Have you ever worn a hearing aid?
Oh, yes, years ago. But I could never work it.
Well, some people have some trouble hearing me. That's why I always bring this hearing amplifier. This is often helpful for people who can't understand me in this tone, so I don't have to shout. It's a headphone and microphone connected together. Let me show you how it works first. And if you like, you can try it and see if it might work.
Okay.
You put the headphones over your ears. And this connects to here, and this is the microphone that I'll be speaking into. Do you think you might like to try it?
Oh, sure.
Great. And you can adjust them so that they fit comfortably over your ears. And I'll turn this on. Is that better?
Oh, yes. Yes.
Great.
It's very good.
Terrific.
Oh.
Terrific. Excellent.
You want me to hold it?
If you would do that for me, that would be great. Great.
I hear you fine.
Wonderful. Now, have you ever worn glasses?
Oh, yes, I think they're in the drawer over there.
Okay, can I get them for you to
Yes,
wear?
please.
Okay, great. There you go. I'll help you with these.
Thank you.
There.
Thank you.
Well, it's wonderful to have you here with us. I understand you came to us from another facility. How's your stay been with us so far?
Well, everybody's been very nice. But you know what? It's cold in here.
Oh,
Cold.
Can I get you something to wear, something warm? How about a cover? Oh, how about your lovely sweater?
Oh, yes, that would be very good.
Great. There we go. How's that?
That's nice. Much better.
Great. Now, what I'd like to do today is ask you some questions about concentration, about your mood, and how you've been feeling over the past couple of weeks. I'd also like to ask you some questions about your routine here at the nursing home, and I'd like to ask you some questions about physical pain. Does that sound okay?
Oh, yes, very good.
Great. Great.
As you can see from April's interaction with this nursing home resident, interviewing is a dynamic, collaborative process. How did she get started? Start by introducing yourself. Convey patience and warmth. Be sure the resident can hear what you say. Speak clearly, articulate. Be careful not to mumble or rush. Although you may need to speak in a louder voice for some residents to hear you, avoid yelling, as this may increase some residents' agitation. Ask the resident if they use or need a hearing or communication device. If they do, help them use it if they need help. You saw April use an external listening device or amplifier. These are widely available and can be purchased for under $50. Many older adults find these helpful even if they have fitted hearing aids. Remember, all items should be asked in the language that the resident prefers to use to communicate with his or her providers. What else can we learn from how April got started? She interviewed her resident in a quiet, private area. This is important because it decreases interruptions and distractions and eliminates background noise that can interfere with focus and with hearing. A private setting also increases everyone's comfort in asking and reporting personal information. April also made sure that she and the resident could see each other. A simple approach is to ask the resident where they prefer for you to sit so they can see and hear you. This also means having adequate lighting and minimizing glare. This simple beginning went a long way towards establishing rapport and conveying respect for the resident. It can also tell us a great deal about the resident.
When I went into the facility, I asked for someone who was cognitively impaired. And the resident that I was assigned, I prepared to do the assessment and attempted to use the amplifier. And when I put it on her, I said her name into the microphone, and her head came up like she heard me and was responding. And when I first walked in, her head was slumped down and her eyes were unfocused. And so it was like, oh wow, this is, I'm witnessing magic here. But immediately her head went back down. And so after a while, I took the amplifier and I checked the batteries and found that they had died. Replaced the batteries, put the amplifier back over her ears, spoke into the microphone. Her head came up. She was able to respond to the questions. She was able to identify that she'd been in pain. We learned that she had a hearing loss. She had a cognitive deficit, but it wasn't as severe as the facility had believed it was.
Once you've explained your purpose and set up to talk with the resident, remember to ask the questions as they appear in the form. If the resident expresses strong emotions, listen and be empathetic but non-judgmental. Do not try to talk the resident out of an answer. Instead, code the question using the resident's response. A helpful approach is to show and tell the item responses. Selecting a response is easier if the older adult is allowed to both hear and read the response choices. The interviewer should both verbally review and show a sheet of paper or card with the response options. Many of you already use this approach when you ask about the pain scale. Keep in mind that any visual aid should be in large, clear print. You don't need anything fancy. Now let's talk about a technique that's very helpful when a resident has difficulty with longer items. If they have difficulty, you can separate items in the mood and preference sections into shorter parts and provide a chance to respond after each part. This method is helpful if a resident is easily distracted or has moderate cognitive impairment, but can respond to simple, direct questions.
Over the last 2 weeks, have you been bothered by trouble falling asleep or staying asleep?
No.
How about the opposite, sleeping too much?
No, I don't sleep too much, no.
Over the last 2 weeks, have you been bothered by feeling tired?
Well, tired, yes, sometimes.
Sometimes respondents give a long answer to an interview item. To narrow the answer to the response choices available, it can be useful to summarize the longer answer and then ask which response option best applies. This conveys understanding while allowing you to address all of the important areas that you need to cover in the initial assessment. This demonstrates to the resident that you are listening to his or her responses, opening dialogue, and building trust. Here's an example.
I also want to know about your appetite. Over the past 2 weeks, have you been bothered with poor appetite?
Have you had to eat any of the food here, huh? I wouldn't fit it to a dog. And then I got my doctor. He put me on a low salt and a diabetic diet or something like that. The food tastes terrible. I can't stand it. It's awful.
So you don't like the food you're being served? I'm going to make a note and talk with the dietitian so that she can get together with you and work on that.
Oh, that's good.
A slightly different approach is helpful when the resident understands an item but has trouble selecting an item response. Sometimes you can unfold the responses by asking an answer in the mid-range of the choices and then move from there to more specific responses.
Over the last 2 weeks, have you been bothered by feeling tired?
Well, tired, yes, yes, sometimes.
Can you tell me how often you've been bothered by feeling tired? 0 to 1 days, 2 to 6 days?
I don't think I could count the days.
Well, would you say that it's been more than half the days or less than half the days?
Well, more than half the days for sure.
Okay, well, do you think that it's been nearly every day?
Well, it's not every day, but yeah, more than half the days, but not every day.
Okay, so you've been tired more than half the days.
Yeah.
A minority of residents will not be able to complete the interviews. If a resident is assessed as being rarely or never understood, you do not conduct the interviews. Instead, you use the alternative staff observation items included in the form. If a resident is able to make him or herself understood at least some of the time, you should attempt the interviews. Even if the interview is not completed, your time has not been wasted. Resident behaviors observed during the interviews can contribute to the alternative staff assessment. Each section gives instructions about how many non-responsive answers should lead the assessor to end the interview and change to the observation items. An answer is considered non-responsive if the resident does not give a response or gives answers completely unrelated to the topic.
Now that we know the basic techniques for interviewing, let's look at the specific interviews. These scenarios are based on actual resident interviews. When using this video for independent training, you should first review the instruction manual to see how each particular interview item is coded. As we demonstrate each scenario, you may want to score the interviews. Then, after viewing the scenario, stop and evaluate your answers using the instruction manual as a guide. Answers are provided at the end of each section.
The purpose of the first interview section in MDS 3.0 is to assess the resident's cognitive patterns. The brief interview for mental status efficiently provides insight into the resident's current condition and helps to identify needed supports. Most residents are able to attempt this brief interview for mental status. Without an attempted, structured cognitive interview, a resident may be mislabeled based on his or her appearance or assumed diagnosis. Now we will demonstrate an interview. Score the interview as you watch. To do this, you need to know that it is Monday, November the 23rd, 2009. Before watching and scoring the interview, review the coding instructions in the manual.
Mrs. Jones. Mrs. Jones. Mrs. Jones, I'd like to ask you those questions now. We ask these questions of everyone, and we do it so we can better plan your care. Some of the questions may seem easy, others more difficult. Are you ready? Okay. I'm going to say 3 words for you to remember. Please repeat the words after I have said all 3. The words are sock, blue, and bed. Now tell me the 3 words.
Bed. Blue. Blue is my favorite color.
Okay. Yes, 2 of the words are bed, a piece of furniture, and blue, a color. The 3rd, sock, is something that you wear. Now tell me the 3 words.
The blue socks are on the bed.
Okay. Now can you tell me what year it is right now?
Don't you know?
We ask these questions so that we can better plan your care. Please tell me the year we're in.
1999, the millennium.
And what month is it?
November. My grandchildren made that turkey for me.
Oh, very creative. And what day of the week is it?
Monday. Monday we play bingo. It's Monday.
You play bingo
So
on
it's
Monday?
Monday.
Wonderful. Now let's get back to the earlier question. What were those 3 words I asked you to repeat?
Blue.
Okay. And something that you wear?
Dress.
Okay. And a piece of furniture?
Bed.
Okay. Now I'd like to ask you some questions about your mood. Would that be all right with you?
The residents' responses provide a total score of 8, indicating possible moderate cognitive impairment. You notice that the assessor did not total the score while talking to the resident. The score was based on the following. C200 is 2, C300A is 0, C300B is 2, C300C is 1, C400A is 0, C400B is 2, and C400C is 1. Although you do not know the reason for the cognitive impairment, your observation of behavior and responses to these specific items will also help you better code the delirium questions C1300 A to D. You also learned that she could use environmental cues and verbal reminders to improve her interactions and recall. Do not be concerned that she used these environmental cues to answer some questions. Those questions should still be coded as correct. The next interview section you will be considering is mood. Before you review the instructions for coding these items, we will review important information about mood disorders.
Why do we ask about mood? Although nursing home populations are at an increased risk for depression, not everyone who is in a nursing home is clinically depressed. In fact, the majority of residents are not clinically depressed. MDS 3.0 uses the PHQ-9, a validated mood assessment, to screen for possible depression in order to identify residents who need additional evaluation.
Asking about mood signs and symptoms is very important because depression is common in older adults, especially in persons that have multiple illnesses or physical limitations. However, not everyone who is old or chronically ill or disabled becomes depressed. Just because it is common, we shouldn't assume that depression is a normal part of aging. It's not, and it's very important that it be addressed. Most persons admitted to the nursing home don't meet clinical criteria for depression and would not score in the possible depression range on the PHQ-9. And don't worry, you won't make someone depressed by asking about these symptoms. We know that asking direct questions about mood can initially seem difficult for care providers. After a few interviews, providers become more comfortable with the questions. A resident's mood has a significant effect on their quality of life. An assessment allows us to know which residents might need our help.
You will see an interview with a resident who represents the 17% of nursing home residents with probable major depression. Because this 17% is an important minority with significant, often unrecognized need, we have chosen to use this example. In this example, we will also be demonstrating several important interviewing techniques. It is unlikely that you will need to use all of these techniques in one interview. It is important to note that 83% of residents will have less severe symptoms, and few interviews will be this complex to complete.
Now, Mr. Royce, I'm going to ask you some questions about your mood and your feelings over the past 2 weeks. And I'm also going to ask you about some common problems that are known to go along with feeling down. I know that some of these questions are going to sound pretty personal, but we really ask everybody to answer them because they can really help us provide you with better care. So the first thing I'm going to do is I'm going to ask you if you've been bothered over the past 2 weeks by a particular problem. And if you tell me yes, that you have been, then I'm going to ask you to tell me the number of days that you've had the problem in the last 2 weeks. And I'm going to give you the choices that you see on this card. So that would be 0 to 1 days, which would be not at all, 2 to 6 days, which would be several days, 7 to 11 days, which would be more than half of the days, and 12 to 14 days, which would be nearly every day. So, are you ready?
Yeah, go ahead.
Okay. Over the past 2 weeks, have you been bothered by little interest or pleasure in doing things?
The past 2 weeks, I don't know. I'm not interested in doing anything. I don't know. I just don't feel like it. I used to like talking to friends, to other people, but I don't do that much anymore. I don't talk. I don't visit anymore.
It would help me to understand how often you felt that way in the last 2 weeks. So, do you think it was 0 to 1 days, 2 to 6 days, 7 to 11?
7 to 11 days.
Thank you. Over the last 2 weeks, have you been bothered by feeling down, depressed, or hopeless?
It's not a big deal. I just don't want to bother anybody.
You are not bothering me when you tell me how you feel. It's really important for me to know if you're feeling down, depressed, or hopeless. I want to know.
Well, actually, frankly, I've been feeling down.
Can you tell me how often in the last 2 weeks you've been bothered by feeling down?
Every day. I feel sad every day, but I don't want to bother people. Thank you.
I really appreciate your telling me about how you feel, Mr. Royce. It's important, and I know that it's difficult, but I want to know so we can help. Do you think that you can continue with some more questions?
Yeah, sure.
Over the last 2 weeks, have you been bothered by trouble falling asleep or staying asleep?
No.
How about the opposite, sleeping too much?
No, I don't sleep too much, no.
Okay, so sleep hasn't been a problem. Over the last 2 weeks, have you been bothered by feeling tired?
Well, tired, yes, sometimes.
Can you tell me how often you've been bothered by feeling tired? 0 to 1 days, 2 to 6 days?
I don't think I could count the days.
Well, would you say that it's been more than half the days or less than half the days?
Well, more than half the days for sure.
Okay, well, do you think that it's been nearly every day?
Well, it's not every day, but yeah, more than half the days.
Okay, so you've been tired more than half the days.
Yeah.
I also want to know about your appetite. Over the past 2 weeks,
Have you been bothered with poor appetite?
If you had to eat any of the food here, huh? I wouldn't feed it to a dog. And then I got my doctor. He put me on a low salt and a diabetic diet or something like that. The food tastes terrible. I can't stand it. It's awful.
So you don't like the food you're being served? I'm going to make a note and talk with the dietitian so that she can get together with you and work on that.
Oh, that's good.
But knowing that you don't like the food, it's also important for me to understand if you have not felt hungry. So over the last 2 weeks, have you been bothered by a poor appetite?
No, I'm hungry.
Have you been bothered by overeating?
What, this food, overeating? What, are you kidding? No overeating.
Food is the problem, I understand, and we're going to work on that with you.
Okay.
I do have a few other questions. Over the last 2 weeks, have you been bothered by feeling bad about yourself?
Well, yeah. Look, I feel bad about myself because I can't take care of myself. Can't even go to the bathroom by myself.
How often would you say that you've been bothered by feeling bad about yourself?
7, 11 days, yeah.
Okay. Over the last 2 weeks, have you had trouble concentrating on things such as reading the newspaper or watching television?
What, watching television? News? I used to like to watch television and the news, but I can't concentrate on that stuff anymore.
Well, I'd like to understand how often you've been bothered by not being able to concentrate. Do you think that it was...
Oh, 12 to 14 days, actually.
It was nearly every day. Okay. Over the past 2 weeks, have you been bothered by moving or speaking so slowly that other people could have noticed?
So slowly? No.
Well, how about the opposite? Being so fidgety or restless that you've been moving around a lot more than usual?
No, wouldn't consider myself fidgety, no.
Okay, one more question about mood. Over the last 2 weeks, have you had thoughts that you would be better off dead or of hurting yourself in some way?
No, not that. I just want to get better. That's all.
All right. I know that some of this has been difficult, and I appreciate your talking with me about your feelings. Our care team is going to work with you to address some of the issues that you talked about that bother you. Is there anything else you want to tell me about your mood?
I think that covers everything.
As was indicated at the start of the interview, we elected to show a more difficult interview so we could show several different effective responses used by the interviewer. Most importantly, during the interview, you saw Rena acknowledge that she'd heard what the resident had said and show sympathy. It was important that she did not try to talk the resident out of an answer. When the resident expressed strong emotions, she listened and was non-judgmental. She didn't have to fix or resolve all issues during that single interview, but she let the resident know it was a starting point and that help was on the way. Allowing emotional expression, even when it is uncomfortable for you as the interviewer, recognizes its validity and provides support to residents. If the resident remains agitated or overly emotional, respond to his or her need. However, it is important to remain calm and reassure the person that you are there to help them. Rena also used echoing or summarizing the resident's statement to reflect understanding and to emphasize the question. She broke apart the sleep and appetite items, and she helped the resident unfold his responses when asked how often he felt tired. Asking the questions as written will help to complete the assessment and will provide a summary score that can also help healthcare providers understand the severity of the mood signs and symptoms. In this resident's case, his PHQ-9 score is 12, indicating the possibility of moderate depression. His primary care provider or mental health specialist should be informed of his responses and score. The care team should also come back and work with the resident to find constructive solutions to facility-level issues that were raised during the interview.
You'll notice the last question in the mood section asks about thoughts of being better off dead or of self-harm. The overwhelming majority of residents will not have these feelings, and don't worry, you won't make anyone have these thoughts or feelings by asking this question in a calm, matter-of-fact way. On a rare occasion, a resident may indicate that he or she wishes they were dead. Although this is rare, it is important for you to know that someone feels this way. We will show you how to appropriately handle this situation should it arise.
Mr. Royce, over the last 2 weeks, have you been bothered by thoughts that you would be better off dead or of hurting yourself in some way?
I feel my family would be better off if I weren't here. I'd be, I'd be better off if I were dead. No. Yeah.
I know this is hard for you.
I mean, I always used to take care of myself. I used to take care of my family. And now I have to rely on other people. I feel so helpless.
I hear how you're feeling, and I want to thank you for sharing this important but difficult information with me. It's important that I understand how often you're feeling this way. Would it be 0 to 1 days or 2 to 6?
Yeah, at least 2 to 6 days.
2 to 6 days. Okay. And I need to ask you if you've been bothered by thoughts of hurting yourself in some way.
Hurting myself? No, not hurting myself. But look, I just don't want to bother other people. That's all.
Well, we need to work together to help you to feel better. So I'm going to talk to the charge nurse and let her know how you're feeling. And it's also important that we talk to the doctor to develop a plan to help you feel better.
Okay.
In order for that plan to be as helpful as it can be, there are some other questions that I'd like to ask you about things that are important to you and about whether you're in physical pain. Would that be okay with you?
Yeah, that would be all right. Actually, I tell you, it's it's a kind of relief to be able to talk these things out, you know.
It's extremely uncommon for residents to have suicide ideation. It is important that we identify the rare resident who is thinking in this way. Let's watch one way to handle thoughts of self-harm should it arise.
Mr. Royce, over the last 2 weeks, you've been bothered by thoughts that you would be better off dead or of hurting yourself in some way?
I tell you, I can't do this anymore. I can't live like this. I think I ought to do something to end it all.
I know this is a difficult time for you, but it's important for me to understand how often you feel this way. Would you say that it would be not at all, several days, more than half the days? The 2 to 6 days?
Several
days.
Several days.
Okay. I know that this is a tough time for you, and what you've told me makes me even more concerned. It's important that we help you to develop a plan to protect yourself and to get help when you feel this way. And part of that plan is going to be for us to talk with your doctor about developing a plan to help you feel better. But before I do that, I'd like to ask you some questions about things that are important to you to help you be more comfortable in the facility. And I'd also like to be sure that you're not in any physical pain. So,
How are you doing? Do you feel like you could answer some questions about your daily care and comfort?
Yeah, I think it'll help, actually. I can answer some more questions.
Okay, and then after we've done all that, I'll ask the charge nurse to come in and we can talk with her about how to help you with those feelings of not wanting to live like this anymore.
As significant and important as this resident's response is, you see that the caregiver did not panic. In cases where residents report thoughts of harming themselves, it is important not to be alarmed. You are with the resident and are providing support by being there. Facilities have protocols for addressing this type of report. Most often, you will ask the charge nurse or other responsible facility personnel to speak with the resident before you leave the room. You saw that Rena went on to ask additional questions. The information provided by completing questions about daily preferences and pain levels can be very helpful in identifying whether pain or unmet preferences are contributing to these thoughts.
The follow-up evaluation is beyond the scope of this video, but your facility should already have protocols to handle the rare situations when a resident expresses or demonstrates the intent to harm themselves. Information about preferences that comes directly from the resident can greatly enhance quality of life and demonstrate respect for the resident's choices.
Most residents can answer questions about what is important to them. You will notice in this section the resident has several response choices. When identifying the best questions and responses, we saw that it is easier to answer a question when the choices match the questions with the experience of the resident. That is one reason that absolute yes-no answers are not always easy to give. This was particularly true when we tested different ways to ask residents about their preferences. We tested fewer response options and found that residents were frustrated if the responses didn't allow them to distinguish between very important and somewhat important, or between not very important and not important at all. Another response choice that deserves comment is important but can't do or no choice. We added this choice after we learned that many residents had preferences that they felt were important but could no longer be achieved. Having this choice made responding easier for residents and also gave their providers important insight into perceived limitations. You should use these response options to interview and to code MDS 3.0. Unlike other interview sections, the residents' responses do not provide a standardized score. In the scenario, you see that the interviewer responds with some solutions during the interview. You can use that approach, or as demonstrated in other interviews, bring the information back to the care planning team to develop resident-specific approaches to follow-up and solutions.
Okay, Mr. Dennis, now I'm going to be asking you some questions about what is important to you in your daily routine. I realize that you haven't been here long enough to set up a day-to-day routine, but answering these questions will help the team learn about what's important to you. It'll also help us plan your care around your preferences so that your stay with us is more comfortable.
But you're being so formal. Just call me Joe.
Okay, Joe.
Yeah.
I'll call you Joe.
Thank you.
So now I'm going to be asking you to tell me about what is very important, somewhat important, not very important, not important at all, important but can't do, or no choice. Now let me explain to you what the important but can't do or no choice answer is. That is if you feel something is important, but you're not able to do it because of health or because of what's available in this facility.
Oh, you mean like dancing, huh? I hate to brag, but I used to be a pretty good dancer. But can't do it anymore.
Exactly. So if you tell me something that is important to you, but you feel you can't do it, this will help us find ways so that you're able to do that or something related to that. Let's say, for instance, dancing. We can set up a music or moving activity that you would enjoy.
Okay, yeah, sounds good.
Okay, so now I'm going to be asking you some questions in regards to why you are here in this facility. How important is it to you to choose what clothes to wear? Is it very important, somewhat important, Not very
No,
important.
somewhat important.
Somewhat,
yeah.
okay. How important is it to you to take care of your personal belongings or things? Very important, somewhat important, not very important, not important at all.
Kind of very important, yeah.
Very important, okay. How important is it to you to choose between a tub bath, a shower, a bed bath, or a sponge bath?
Oh, I prefer a shower, but I guess that's somewhat important.
Okay. How important is it to you to have snacks available between meals?
Not very important.
Not very important.
What's the old belly here?
Okay. How important is it to you to choose your own bedtime?
Very important, but I don't think I can do it here. You know, for example, last night they put me in bed at 8 o'clock. Now, I know they're very busy and they've got schedule to take care of, but 8 o'clock, it's I'm just not ready to sleep at 8 o'clock.
Okay. I will make a note of that you felt that you didn't have a choice and that you have a preference for your bedtime, so that you do have a choice while you're here at this facility.
Oh, man, good. Thank you very much.
Okay. How important is it to you to have your family or close friend involved in discussions about your care?
Very important. I want my daughter to know everything that's going on.
Okay.
And so it's very important.
All right. While you are here in this facility, how important is it to you to be able to use the phone in private?
Privacy. It's very important.
Very important. Okay. And while you're here, how important is it to you to have a place to lock your things to keep them safe?
You mean my valuables?
Right.
Well, I don't have any valuables, so it's somewhat important.
Okay. All right. While you are in this facility, how important is it to you to have books, newspapers, and magazines to read?
Very, very important. I love magazines, and I enjoy a good book, too.
Okay. How important is it to you to listen to music you like?
Very important.
What type of music do you like?
Particularly opera music. Did you ever hear of Renee Fleming? She's an opera singer.
I've never heard of her, but I enjoy opera music.
She's an opera, and she sings like a dream. You should hear her.
So, how important is it to you to be around animals such as pets?
Not very important. I used to have a dog, always had a doggie, and enjoyed them, but now, no, it's not very important.
Okay. How important is it to you to keep up with the news?
Very important. The world is going to hell in a handbasket. I want to know what's going on.
Okay. And while you're here, how important is it to you to do things with groups of people?
Groups of people. Well, let me think about that. No. Not very important.
Okay. How important is it to you to do your favorite activities?
Like what?
Let's say, for instance, hobbies or things you might be interested in.
Oh, yeah, I used to love to do crossword puzzles, but not my eyes, but the squares are getting awful small now.
Okay,
Yeah.
so would you say that it's very important, somewhat important?
It's very important.
Very
but
important.
I can't do it anymore.
Okay, well, I'll make a note of that, and I will share this with the team so that we can make the print on boxes bigger for you.
You can do that?
Yes, we can.
Oh, thank you.
You're welcome. Okay, how important is it to you to go outside to get fresh air when the weather is good?
Fresh air is very, very important, but unfortunately I can't walk as far as I used to.
Okay, I'll make a note of that. How important is it to you to participate in religious services or practices?
Not very important. I used to be more religious, but getting old, I guess.
Okay. Well, thank you very much for answering these questions. These answers are very helpful to us. I will share this with the care team, and some of the team members will come back to talk to you about things you identified as important or important but can't do. Is there anything else that you feel is important that you would like to share with me?
I think we've covered a lot. We've done very well.
Yes, we did.
If everybody in this facility is as nice as you, I think we're going to enjoy it here.
Oh, thank you. I appreciate that.
But if I think of something, I'll call you.
Okay, thank you.
Yeah, well, thank you. It's been a pleasure. I've enjoyed this.
So tell me more about Renee Fleming, the
Renee
opera
Fleming.
singer. I'm not familiar with her.
First of all, she's gorgeous.
Individuals in long-term care settings continue to have distinct lifestyle preferences. In the national test of MDS 3.0, the overwhelming majority of both short and long-stay residents appreciated being asked about what was important to them. The care planning team will consider those items that were very important or important to Joe. They will also consider those items he rated as important but can't do, no choice, and assess whether any perceived barriers can be removed or a substitute be provided. Preferences may change over time. Therefore, the assessment of activity preferences is intended as a first step in an ongoing dialogue between the care provider and resident. The pain questions in this interview assess the presence of pain, pain frequency, effect on function, intensity, management, and control. Information about pain that comes directly from the resident provides symptom-specific data for individualized care planning. Pain can cause suffering and can interfere with rehabilitation and be associated with low mood. Most residents who are capable of communicating can answer questions about their pain. Testing shows that they recall moderate or severe pain even with a 5-day look back.
All right. Mrs. White, let's move on to a question about physical pain and how you've been feeling in the last 5 days, okay? Have you had pain or hurting at any time in the last 5 days?
Oh, I don't want to bother anyone. It's not so bad.
I'm here because I need to know how you're feeling so we can help you. And please don't worry that what you're telling me is a bother. Have you had pain or hurting at any time in the last 5 days?
I'm in pain a lot. My hip hurts. I had surgery. They said I fell and broke it.
Okay. How much of the time have you experienced pain or hurting in the last 5 days? Would you say almost constantly, frequently, occasionally, or rarely?
I'm in a lot of pain.
Okay. Would you say almost constantly or frequently?
Almost constantly.
All right. I'm going to talk to your doctor and care team about how often you're in pain. I just have a few more questions to ask so we can get an accurate picture of how much pain you're in. Now, over the past 5 days, has pain made it hard for you to sleep at night?
Yes, it hurts too bad to sleep.
Okay. Over the past 5 days, have you limited your day-to-day activities because of pain?
Yes, it hurts too bad to move. I just want to be still.
Okay. And please take a look at this pain scale and rate your worst pain over the last 5 days on a 0 to 10 scale, with 0 being no pain and 10 being the worst pain you can imagine. This will help me give the doctor accurate information.
8.
8, I see. Okay. All right. We're going to work with you on that pain. And I'm also going to check to see what medications your doctor has ordered for your pain right now. And I'm going to share what you've just told me with your care team so we can get started on helping you to feel better right away. Is there anything else you want to tell me about your pain?
No, thank you.
You're welcome.
Some observers have expressed concern that residents may not complain and may deny pain. However, the regular and objective use of self-report pain scales enhances residents' willingness to report. In fact, multiple studies have shown that rates of self-reported pain are often higher than observed rates. This resident had not let anyone know about her pain, and by limiting her activities had avoided frequently demonstrating signs of pain. April could have shown the resident the 0 to 10 scale or the verbal descriptor scale to rate the intensity of the pain. She used the 0 to 10 or numeric rating scale to ask Mrs. White to rate her worst pain and gave verbal definitions of the 0 and 10 values. April may have used the 0 to 10 scale because the resident had used this scale before, or it is preferred by Mrs. White's providers. If Mrs. White had had difficulty using the 0 to 10 scale, April would have tried the verbal descriptor scale, where the resident would have been asked to rate the intensity of her worst pain as mild, moderate, severe, very severe, or horrible. Nursing homes invest time and resources to complete MDS assessments. The direct interview items will help ensure that time is well spent in obtaining accurate resident-centered information. This high-quality information can provide a solid foundation for additional evaluation and care planning in several areas that are important to resident quality of life.
Every day, you bring your best to work in long-term care environments. Helping vulnerable populations have the best quality of life is evidence of your commitment to your field. Along with your training manual, this video will be a useful tool in helping you understand and implement best practices when conducting direct resident interviews. We hope you will use it, along with the information learned, together with your care plan team to create effective resident care plans. Thank you.
I actually look at it as a privilege to come to work and work with the residents and the people that are entrusted to our care here. Nurses have an important role in the healthcare continuum and really improve the quality of somebody's life on a day-to-day basis.
My work is very fulfilling. It's very fulfilling because every day you are presented with a new case. You don't know what you're going to see the day you arrive to work.
There are so many different facets in terms of, what I can see about residents and helping them to have a high quality life. There's just a lot of satisfaction involved with that.
I'm passionate about the fact that I help people.
What I value most about my work is caring for those that are in need, providing care and service to my community.
I love it. I wouldn't do anything else.